All right, I have 12 o'clock on my clock, so let's go ahead and get started. Hi and welcome everyone to our UNC Injury Prevention Research Center webinar series. Thank you for joining us today. My name is Ciara Scott and I am a project manager here at the center, and I'm going to be moderating today's webinar. We're going to begin today's webinar with a quick welcome from Dr. Steve Marshall, who is the director of our Injury Prevention Research Center. And then he's going to introduce you all to our speaker, Dr. Joe Hart. And we'll have a great and informative presentation from Dr. Hart, followed by some dedicated time for discussion and answering questions that come up from his presentation for you all. And then we're going to wrap things up today by just briefly forecasting the other webinars coming up in our series. And so before we get started, I just want to give one quick housekeeping update, which is just that for right now in the beginning of this webinar, we have disabled your ability to unmute or show your camera just so that we can protect the recording from any accidental disruptions. But later on in the presentation, when we get to the question and answer, you will have the ability to unmute so that you can ask questions and engage in discussion with the presenter. And if you have questions that come up throughout the presentation, feel free to also just drop those directly into the chat, and I'll be monitoring the chat and collecting questions, and then we'll make sure that we get them to Dr. Hart at the end. And so I think those are all the housekeeping updates I have for you all. And so I'm going to pass it over to Dr. Steve Marshall, who, as I said, is the director for the UNC Injury Prevention Research Center.
Thank you so much, Ciara. I really appreciate the introduction, and thank you also for all of the great and outstanding things you do for our center to keep it running. Much appreciated. You don't know how much it's appreciated, actually. It is a great pleasure to welcome Dr. Joe Hart. Joe is the Norfleet Rainier Distinguished Professor of Orthopaedics, and he's Vice Chair for Research in UNC Orthopaedics. And Joe, I think you're actually maybe the first Vice Chair for Research in the Orthopaedic department at UNC, at least the first one in my experience. So you have the honor of being inaugural, and also all the trailblazing that comes with being an inaugural Vice Chair for Research in the clinical department. Dr. Hart is a clinical research scientist. He has many diverse interests in musculoskeletal health. He has done a lot of work on post-ACL reconstruction and patient outcomes following ACL, and has a very patient-orientated research agenda that many of us appreciate. In the early phases following recovery from serious knee injuries like tears to the ACL, there's a lot of capacity for rehabilitation techniques that make a big difference to the patient in terms of improving muscle coordination, improving muscle strength, but also improving the overall coordination of the lower limb and the whole body. As some of us are an orchestra, and where you can all do with a little bit of fine tuning. Others of us, like myself, their body is more like a cacophony of disconnected joints. But for the people who are an orchestra, post-injury, I think that these techniques are really the cutting face of where sports medicine should be in patient-oriented approach. So I'll hand off to Joe, and looking forward to his talk today, evaluation techniques and treatment approaches that enhance patient outcomes, recovery in patients recovering from the injuries. Take it away, Joe, and delighted to have you here.
Thank you, Steve, and thank you, Ciara, for all your help setting this up and for being so welcoming to everybody. Thanks again for having me. I'm going to just go ahead and start sharing my screen. Ciara, just give me a thumbs up if that looks good. Awesome. All right. Thanks. All right. Yeah. Thanks. Sorry for the long title. It's also the abstract of my talk. So just some quick disclosures, as is customary. So just a little about me, for those of you who don't know me. My education background, I was a pioneer, a mountaineer, then a cavalier, and now I'm a Tar Heel. So little inflection point. My background is actually as an athletic trainer. I'm still certified and licensed in the state of North Carolina. I spent the first part of my career as a professor of kinesiology, where I did most of the biomechanics and instrumentation work for the department, plus clinical skills in our athletic training program at University of Virginia. I was also, in my spare time at UVA, I was a director of clinical research for Orthopaedics, where I built a clinical trials infrastructure and helped our faculty, trainees, students kind of navigate the research process to be successful and achieve their goals. And ultimately, I wound up here, which has been a great journey so far. I've been here since January of this year, and I have to say I've been super impressed and excited to be a part of this team. So so my plan is I'm going to speak for about 10 or 15 minutes about the work that I'm doing and some of our the work that our department is doing, and hopefully after that we'll have some time to engage in research. The biggest and most exciting part of the work that I do is working as a clinical scientist at the point of care. At University of Virginia, I developed a musculoskeletal assessment program that we called LEAP, Lower Extremity Assessment Program. And the goal of the LEAP program was to provide precision research grade data in serial time points to help patients, their families, their healthcare providers, their teams make important healthcare decisions about how they're advancing, how they're progressing, and time when to at the appropriate time to discharge from care and release to unrestricted physical activity after major musculoskeletal injuries. So at UVA, we have a data set of nearly of over 1,000 unique patients and nearly 2,000 data points from various assessments. We focused on ACL reconstruction and navigating the postoperative process, but we've scaled that to other parts of the body, hip, ankle. We tried shoulder, didn't really work out, but we're hoping to try again. So I brought that program down to UNC. And this musculoskeletal assessment program is really important for us because it provides research grade data, precise data, and gives it back to its rightful owners, to the people that we're collecting this from. The one thing different, again, in my years, I've kind of professed about being a point of care research scientist, but I've always been in a lab, in a building, usually in the basement of that building with no windows, like typically you'd have with kinesiology labs. But now I'm actually in our clinic, on our clinic floor. We have an oversized exam room that's adjacent to other providers, so that patients can actually engage in the research process and the scientific process, and have opportunities for clinical trials engagement along their care, along their journey throughout our health system. So with patients with ACL reconstruction right now, our program, we're seeing patients. This program is building. We're continuing to build. Our plan is to see patients prior to their surgery for an assessment, then 4 months, 6 months, and 8 months, and then annually thereafter. We merge with the patient journey, and hopefully we'll scale to other patient groups. We have the equipment, we have and we're building our resource platform to hope to build that to other people. This little QR code in the lower right hand corner, I will put that back up on my last slide, but this is a video from the UVA version of the LEAP program. If you want to know exactly what we're doing, it's basically the assessment of strength, balance, performance, and patient-reported outcomes. One of the most important pieces of this program. Oops, sorry, I'm having some. One of the most important pieces of this program is the takeaway, providing the patients with something that showcases their results from their tests, that can be in a digestible, tangible format that they can see and use, and for their to guide their care and other healthcare decisions that are necessary. This is an example of a LEAP report that our department, my postdoc, and my research coordinator, Devin Kelly and Gad Delbiondo have been working really hard to develop into a more light blue version of our prior LEAP report. So obviously, it wouldn't surprise you to say that patients recovering from major knee joint injury have major muscle deficits in the muscles that surround the joint. So this is kind of the result of our first few hundred patients from back at UVA, looking at our pass rates. We use a red light, yellow light, green light system based on the extent of muscle symmetry. And so the isokinetic knee extension, which is this graphic right down here, you can see that we have nearly only a 13% pass rate. So those that have greater than 90% symmetry, and only 30% of our patients who are at between 6 and 8 months after their surgery, which is pretty alarming. But what we've also noticed is that this pattern of symmetry is non-uniform. We see a lot of patients, especially younger athletes, who are passing functional jumping tests where they appear to be ready to return to their sport, are doing so in the presence of profound muscular asymmetries. So again, this is kind of a unique pattern that helps us identify potentially an underlying source of compensation or adaptation that might be unique to this patient subgroup that may be important to their healthcare journey. There's tons of information. We probably published nearly 70 peer-reviewed papers from this data set, from looking at anywhere from nerve blocks to tunnel placements to postoperative rehab to sex and graft types, et cetera, all things that we look at identifying patterns. One thing, this is probably the most important finding that I've published over the years, is the power of information. So we do serial assessments over a period of time. We intentionally do an interim report in the middle of recovery, at around 4 months after the index surgery, and then another one 2 months later, then another one 2 months after that. So when we started this program, nearly 10 years ago, we did one single assessment at the time where we thought a patient was ready to return to their pre-injury level of physical activity and be released from care. But we started doing interim reports so that patients can use that information from which to guide their next steps of their therapy. And we found that just a simple addition of adding an interim musculoskeletal evaluation, not only did that improve strength outcomes in the patients that were being seen at the time of their return to sport, but patients were feeling better. They were reporting higher levels of perceived joint function at their second test. This is the power of information. So it's super important. I think that if nothing else, this was worth the trouble of doing all of this. So in the rest of my time, I want to talk quickly about some of the projects that I'm currently doing, which will highlight the initiatives that are kind of important to me as a scientist. So right now we're currently enrolling a study that's NIH funded. It's a multi-site trial between us and Virginia Tech, where we are using this musculoskeletal assessment platform to predict who's going to get re-injured after their first time ACL reconstruction. Typically, what we've seen in the past is up to 1 in 4 patients who elect for a first-time ACL reconstruction will have a second injury, either to their injured knee, a graft re-rupture, or a contralateral ACL tear. So we want to know why. So we're using this musculoskeletal assessment platform combined with wearable technologies, in this case, instrumented insoles that go into the shoes, into the participant's shoes, plus a myriad of other information to enter into a predictive algorithm to understand who is at higher risk for ACL injury. We're also doing a study on, in the spirit of musculoskeletal assessment, a study that partners with the National Football Leagues, hosted at the University of Wisconsin, but with a host of other collaborators. Australian Catholic University, the American Medical Society of Sports Medicine, Brigham Young University and us, plus an imaging biotech company called Springbok Analytics, which is a company that I co-founded through my research at UVA. We're using a series of data points, including three-dimensional muscle features plus tendon features, fatty infiltration plus biomechanical analyses to help identify reasons for hamstring strains in American football players. This is the largest study of its kind to help understand and predict who's going to have injuries and re-injuries to their hamstrings in American football players. We're in our first of 3 years of injury tracking right now, actually. And then the other pieces that I'm really interested in are developing ways. We've identified the problems. You know, people get injured. People have a hard time getting back into their sports, and they suffer from elevated risk for re-injury. But one of the things that I'm super interested in especially stemming from my career as an athletic trainer, most of my experiences were in a rehabilitation clinic setting and at the high school setting. But so rehabilitation is a big part of my research interests. So we developed this kind of a way to make rehabilitation fun and engaging. This is a study that we just finished up at UVA. We're currently processing data, and we submitted a grant for a phase 2B clinical trial. But this was funded through the National Institute on Aging. We did a 50-patient clinical trial that basically we designed a series of video games that was driven by EMG biofeedback, so little wearable sensors that were put on target muscle. So in this case, we're doing quadriceps-centered therapy, but instead of having a patient do just 10 sets of 10, we had them play a certain level that was specifically designed to target a particular aspect of muscle function. So in this case, in this top left, you can see it's an up-down task that's centered around knee extension exercises. They're navigating through a fictional tropical island, delivering medical supplies to typhoon victims, which is this video game base. And then this one in the middle is a kayaking game where it's kind of a left-right weight shifting exercise during a squatting exercise. And we have a bunch of other levels, you know, horseback riding, picking up trash. There's rescuing puppies from a cave level. So all sorts of things to help guide patients through therapy. And then finally is my work in imaging. Years ago, we started studying muscle size and shape using MR imaging, and it's fairly cumbersome to the process of image segmentation. For any of you who have done something like this, it takes hours, dozens of hours. In fact, to segment a single scan that goes from malleoli to T12, it takes about 55 to 60 hours of drawing lines around muscles. So the company that I'm involved with was able to create an AI-based algorithm to auto-segment using computer software that renders these really cool-looking three-dimensional models to show muscle volume. And also expresses it as a function of symmetry, where in this case, anything that's blue is bigger than the other side, anything red is smaller. And you can map this out in different ways to start to identify patterns of muscle volume distribution and how muscle volume distribution responds to injury and disease. So this is one of the examples, just a couple of cases that we did in four patients with ACL reconstructions, one or with ACL injuries, and you can kind of see how these patterns vary. And you know what's unique is the fact that number one, atrophy is not the only pattern we're seeing. That not all muscles are red. Some muscles are upregulating and getting bigger to theoretically and hypothetically compensating for other atrophic patterns. But this is an example of a patient with a first-time ACL injury, a patient recovering from a first-time ACL reconstruction, and then patients with multiple repeated ACL reconstruction. And you can see how the pattern just gets more and more non-uniform and erratic, showing that this kind of pattern of compensation and muscle volume distribution and redistribution as the patient has recovers from injury and suffers from re-injury. And this area is super interesting to me, and I'm definitely invested in using this this technology to understand other aspects of injury risk and injury recovery. For example, we've used clinical scans of rotator cuff muscles. Right now, this is a current SBIR grant through that's going through University of Virginia, looking at fatty infiltration of rotator cuff muscles as a predictor for outcomes after rotator cuff surgery. We've done quite a bit of work with amputees. This is a patient with idiopathic scoliosis, a patient with intramuscular tumors. The scans can look at scar tissue, edema, and tumor. So we can look at how and not only how the particular muscle is affected, but how the surrounding musculature responds to those types of injuries and other patterns. And then finally looking at, I think the real cool thing is looking at how muscle volumes change over a period of time. So the notion of aging-related sarcopenia, and how not only muscle volume changes, but fatty infiltration, muscle quality changes over a period of time. This is an example of a young person with a joint injury, and they have some muscle volume distribution patterns that have changed. But then here's a person who's older with progressive muscle disease, that you can see not only are muscle volumes smaller and distributed, but their fatty infiltration is much more, or much less contractile tissue than this younger patient, showing an age-related change. So again, getting back to back to the department level, away from my own personal research, but with my onboarding and my charge for this department is really expanding a well-balanced research program, and in doing so, improving patient outcomes, and providing a framework and a platform where people in our region and our state can engage in the scientific process and have access to the best and most novel therapies that are available through clinical trials and other platforms, and in doing so, being leaders in musculoskeletal health. Right now, we're in kind of a phase of growth. We have 2 new hires that we're currently searching and reviewing applications. We're hiring a basic scientist as a joint hire with biomedical engineering, and we're hiring someone in clinical informatics as a partnership with radiology. And we have extraordinary, long-lasting and growing relationships with exercise and sports science, physical therapy and PT services, Thurston Arthritis Center, Biomedical Research Imaging Center, and then also, our pride and joy are our students and trainees. So kind of expanding the opportunities to medical students, to residents, and fellows. In fact, we through Orthopaedics, we've developed this bi-weekly orthopedic research group meeting for medical students who are interested in orthopedic research and don't have specific projects to work on, just a platform to discuss orthopedic science and musculoskeletal wellness, and a group of people with like interests. If you're interested in that, or have medical students that are interested in joining us, it's all are welcome. This is our current research team at UNC Orthopaedics, our own internal pride and joys. These are all folks that make our clinical research programs happen. In addition to our medical students, residents, research resident, which we have every year, we have a dedicated research resident, and then our enormous list of collaborators. If you haven't done so already, our department webpage showcases our current orthopedic researchers. I don't know if you can see that or not, but just scrolling down, you can see the just a number of orthopedic faculty that are engaged and dedicated to research. And the conversations that I've had over the last few months have only reinforced my personal enthusiasm for working with these incredibly talented physicians and scientists. And I encourage you all to do the same if you have interest in orthopedic and musculoskeletal research. That's all I have. Please follow us on Twitter and follow our hashtag on both Twitter and Instagram, where our Twitter account is UNC Ortho and our hashtag is UNC Ortho Research. This is the QR code link to the LEAP program video if you're interested. And if you are just dying to send me an email, you can use that email address or that QR code. Thank you very much for your attention.
Thank you so much, Dr. Hart. That was a great presentation. I have not seen any questions in the chat, so I just want to give a reminder to folks, you can drop your questions that you have for Dr. Hart into the chat. Oh, we've got one that's come in. And so I'm also going to give you the option to unmute yourself. So I'll throw this question to you, Dr. Hart, and then Matthew, feel free to jump in if there's any more context that you want to add. But we have a question from Matthew Reagan that is, what is the best way to get involved in orthopedics or exercise science research?
Yeah, great question. It's, reach out to faculty in the departments that have, common interests that align with your own research and educational goals. And I feel like websites and faculty profiles are great ways to get to know what faculty are doing as a bridge to having conversations with people. We are in a very student-centric and academically friendly environment. I can't imagine any faculty in a university setting would say no to talking to someone who's interested in joining or getting more information about a research program. I think one of the challenges is, and Matthew, I'm not sure what level of training that you're at right now, or if you're a faculty student member yourself. But I think one of the common misconceptions is that we as scientists have studies that are ready and kind of queued for helpers, and some people do have that, but it's not always the case. So getting involved, having conversations, and staying connected and being present are kind of keys in my experience to getting involved and staying involved. First year medical student. So yeah, if you are a medical student, then please reach out to me directly, and I'm happy to get you to have you join our bi-weekly research discussion group.
All right. We have another question in the chat from Deanna, which says, did you follow a specific post-surgical pain management protocol that you found to be effective in advancing recovery times?
That's a good question. So at UVA, the post-operative protocols were fairly standardized at the site, and I don't know what they were. I'm sure they had a combination of both intraoperative pain control through anesthesiology and post-operative pain control through medicine and rehabilitation. But those it's a good point. We never looked at that aspect of post-operative care and how that impacted 4 and 6 month outcomes. We did look at nerve block types at one point in patients with ACL reconstructions, because at the time we were thinking that patients who were having femoral nerve blocks were experiencing worse strength recovery outcomes, because the actual medicine used during the anesthesiology process was kind of affecting the ability to conduct signal. And that wasn't the case for us. We did not see any patterns with femoral nerve blocks. However, we did see patterns with sciatic nerve blocks. So for patients who were having semitendinosus gracilis grafts, the physicians would prescribe sciatic nerve blocks, and those were affecting hamstring strength recovery, which was an interesting finding for us. In fact, it changed the practice at UVA. They no longer did hamstring nerve blocks because of that.
All right. Do we have any other questions from the audience? We have time for maybe one more.
Well, Joe, do you want to briefly mention the Sports Medicine Institute and at UNC and our efforts to stand up a comprehensive research and clinical care facility on the campus, just briefly? Yeah, that's a great way for people to get involved.
No, absolutely. So please do. And I don't know if you have a link available, Sierra, to the Sports Medicine Institute, that'd be great to put in chat also. So the SMI is something that I joined when I came here. It's the brainchild of David Burkhoff and Brian Petrosimone, as a collaboration between orthopedics and exercise and sports science, and it has since expanded to many other units across campus. They have monthly meetings. The most recent one was last night, in fact. And the whole concept is to have a one-stop shop for comprehensive musculoskeletal care in sports medicine. I mean, the future right now, the SMI as an institute is kind of there's not an actual clinic space or a space that you can go. It's more of a collaborative venture. But in the near future, we hope to change that with clinic sites, research facilities, performance facilities, in a way that can deliver care, sports medicine care, to people in our region, and to advance research, education, and clinical care comprehensively at UNC. Thanks for that, Steve.
Yeah. Thank you so much, Dr. Hart. That is all the time that we have for today for questions. And so just quickly in the chat, I've dropped a link. I have dropped the link to the Sports Medicine Institute for those interested. I've also dropped the link to our post-evaluation survey. If you all have that chance, we would just really like you to quickly complete it. It's a short survey. We just want to gauge your interest in this webinar series and potential topics. And then you also have an opportunity to sign up for our listserv if you want to continue to get notifications about our events. And yes, as Steve has mentioned in the chat, feel free to follow up with Dr. Hart if you have other questions. I'll be sending a follow-up email, and I'll include his contact information for anyone that's interested. And then also, as a reminder, this webinar series will be hosting webinars monthly. We host them on the second Wednesday of each month. It's going to be going on from now until May of 2023. And so we're going to have different speakers each month. And I'm going to drop a link in the chat right now to our website where you can find the schedule. Next month, we're going to have a presentation on December 14th from Dr. Vanita Embry. And she's going to be speaking to some of her criminal justice reform work. And so I hope that you all can join us for that. Again, if you look at the website, you can find the schedule, and I will send a follow-up email with this information as well. So thank you all so much for your time. And I hope that you have a great rest of your afternoon. And thank you again so much, Dr. Hart.
My pleasure. Thanks for having me.
Of course.
Thank you very much, everyone. Thanks, Joe, and thanks, Ciara.
Yeah, thank you. Bye, everyone.